West Bromwich Albion, sort of performance director there. There'll be a lot of focus on Christmas, a lot of focus on the games at Christmas and getting through that. And, people work very, very hard to manage injury risk. Actually, probably the risk comes straight afterwards when you're into FA Cup games, whereby, people may want to rest.
Yep.
And then you draw a big team in the third round in the FA Cup or the fourth round, and the games your players want to play. As with all things, I think, you can maintain that period of high risk. And when that high risk period ends and you let your guard down and maybe you don't do things so well, that's when things can unravel.
Yeah. Okay. So as a performance director, how do you manage that load? Or is it a load management issue in liaising with the manager to try and flag up, okay, who are your key players who might be more at risk, and how do you suggest or provide that information? Does the manager listen to it, or does he just go, I don't want to know, I need to win these games?
So now typically, 5 years ago, or even 10 years ago, you might have been thought of as being innovative by managing that. Now everybody has the knowledge and the tools to do it. So we know the optimal loading for a player over an average week. Now in training, you can control that. It depends on your relationship.
And is that with, say, GPS data a lot of the time now?
So with movement analysis, typically Catapult, StatSports, or one of those systems whereby a mixture of GPS and accelerometry and heart rate data, and you can get some really good data about that. So in training during the week, you can work to prescribe metrics, so you can monitor in real time, and when a player has hit their prescription, then you can withdraw them.
Yep, okay.
Now, not every club is going to be willing to do that, but that's important. And then so you can control the training load, more difficult to control the match load, obviously.
Yes.
Which depends on rotation, tactics, what type of style you're playing, and all those other factors which are really evident in football.
And because it's such a high cost to a club, if a key player, someone like Man City's De Bruyne, who missed quite a big chunk, was at the start of the season?
Yeah, hamstring injury.
Is there a willingness for managers to take on board this information now?
So, the Premier League run a conference with the NFL every year. And it's a standing comment from me. So they'll have people there who will say that AI and injury prediction is the future of success in sports. Now, to a degree, you may have a point. In my experience, so at a smaller club, when you're going in, you've got fixed resources. And you go into a manager and say, look, I'm really sorry, but your key centre-half, his injury risk has gone up from 20% this week to 26%. They're going to play him. So, I think elite sport, competitive sport is all about people. That's why we love it. And there needs to be that level of human input into it to, I think, really, get the best results.
It's a science, but it's almost a pseudoscience in that there's an art to getting that human feedback, keeping a human in the loop almost.
So I have a bit of a quandary about that. So I always tell people that when, I'm involved in a performance-related service, an elite sports service, it's data-informed rather than data-led. And I think that's right. But does it mean that if you're only data-led, then as soon as there's an easy option or an easy way to avoid a difficult decision, are you allowing yourself to do that? So I think, you've got to be quite mindful of the philosophy you run and how you operate it.
Because I think a stat that I read previously was that the cost of injury to Premier League clubs is enormous, and they lose over 300 million in wages a year due to injuries.
That sounds perfectly feasible.
Yeah. So I mean, balancing this out is pretty critical for the performance team and medical team to be able to have those good, easy working relationships with the manager, and ultimately it's going to be the manager's decision, isn't it?
Yeah. I mean, there's another sort of interesting paradox, and I think you have to come back and revisit these things all the time. So, as in all walks of life, good communication is absolutely key. So, there are a number of sports scientists, eminent sports scientists in football, say, look, you know, we're placing too many limits on players. We just need to really go for it, and you know, improve fitness, improve all those elements that we
parameters,
know are important. Now, you can do that, or you can try to do that, but you know, while you're doing that, there is going to be things going to get worse before you get better.
Yeah.
And as long as you accept that as an organisation, then that may be something you want to do.
Yeah.
But you know, what you can't do is
because your soft tissue injury rate will probably increase as you're trying to build. As you're trying to build that fitness levels. Yeah.
But what you can't do is, you know, I think either ignore or excuse, you know, that short-term risk, and then blame people when it goes wrong, and you know, which is what happens. So you know, as long as the organisation has a sort of medium, longer-term strategy to improve that, then I think that's acceptable. As long as you know that there's a risk that you could get a lot of injuries, and there's obviously consequence to that.
Yep. Okay. So, with the fixture congestion or the end of season injuries, is that down to sort of central fatigue? Is that, you know, what is that phenomenon? Is it, you know, we sort of liken it peripheral and central fatigue. Is central fatigue the whole central nervous system just becoming knackered?
Yeah. I think, you know, again, you know, talking about you know, traditionally in the football calendar, except in the years up until now when you've had a major tournament, you know, players are guaranteed 6 weeks off to you know, recharge, both mentally, physically, psychologically. And when that doesn't happen, then all those elements are going to contribute to your increased injury risk. Yeah.
I mean, because now, you know, the Premier League clubs, you know, Man City, Chelsea have just gone over to the Club World Cup, and they're playing in, I think in Philadelphia. Chelsea played the other night, and you know, they're starting at 9 p.m. But a horrific heat. Yeah. Yet no break. Then coming back, and you know, there's only a couple of weeks before the Premier League season starts. So if you're mapping out, you know, how do you manage that? Are you then going, okay, right, I've got to take a long-term view, and I've got to give them a 4-week break or a couple of weeks just off, minimal training, and then let's slowly build them back in?
So the first thing to say is that Premier League volume doesn't change, 38 games. So I would say that's a bit, so it's things around the Premier League that are changing.
So stuff like FA Cup replays,
FA Cup replays,
Champions League, Europa League,
Nations League, you know, international fixtures, all of those things are adding to the player workload. And it's inherent on the club. So if a club chooses, you know, perfectly at liberty to go and play in a, you know, in a tournament such as the FIFA World Cup, then unfortunately it's inherent on them to manage their players players and staff when they get back. Which is, you know, I do have every sympathy with them because it is a very challenging situation.
Yeah. And from a performance point of view, is the right idea to accept that, okay, they probably need several weeks off, but if you pull half the team out, how are you going to manage that?
I mean, these clubs have incredibly dedicated performance professionals, medical staff, physio, sports scientists, and they're incredibly well run. So I have every confidence they'll make, you know, the right decisions to safeguard player welfare. I have no doubts about that at all.
So touching on, you know, we often see a couple of different types of injuries, and we talk about perhaps that the soft tissue injuries are often the preventable ones. How are they preventable? Is that what you alluded to before, that actually you've got to get players fitter, you've got to get players stronger, you've got to build their resilience to cope with either, say, a Jurgen Klopp style of play where he's playing that very high press, or is it managing their workload more, or is it everything?
Both. So I think recovery is key.
Yep.
So, and certainly that is, so there's two things when you step outside of the elite sport panel, which is I see a lot of problems with patients. One is with recovery
Yep.
and not enough thought given to recover and how you do that. Secondly, it's training periodization. So how you train how you train different energy systems. You maintain your strength component, but you make sure that you get enough rest to go into games so that
Yep.
you're in the optimum condition you can be.
Yeah. And say if we take, okay, football's different really.
Yeah.
It's much harder to sort of maintain that periodized sort of training program almost because their training is.
Well, I mean, it's easier if you're not playing in Europe.
Yeah.
So if you're playing, 38 games a season plus cup games, it's a lot easier to manage. Now, if you're, Europa Cup or Europa League or Champions League, and you've got a lot of travel and a lot of late journeys home, it's tough.
Yeah. And that periodization is almost the old sort of theory of having, 3 hard weeks, one sort of recovery week, allowing the body to settle down, but you're making sure that you're optimizing all those different energy systems and strength and power.
So probably you look at the microcycle, that's from over a week. So you have a match day plus one, which is really related to recovering effectively. Match day plus two, which is whereby you may have a really carefully managed training session and you do your higher volume work during the week.
Yep.
Now, I think the really interesting thing for me and thing that I was always interested in is if you run a really well organised and well scheduled S&C program. When do you time your minimal strength dose during the week? What day of the week is that?
Minimal or maximal strength dose?
No, minimal strength dose. So in season, you're looking at, bearing in mind you want to avoid fatigue. You want to look at the minimal dose you can have to maintain strength gains that you've
built up
achieved
either
and
in
you want to
pre-season.
maintain. But you've got to do that at the right time so you don't overload it and you don't go into games fatigued.
So when is that, in your opinion?
Well, so it depends. I think it depends on the volume you're prescribing. So getting the volume right and making sure probably you got
which is going to be different for each almost each different individual.
Yeah, and there's going to be those parameters. Okay, so velocity-based training and all those things that we look at in sports, and probably at least 48 hours before a game.
Yeah, and then probably not, about 48 hours post-match as well.
Yeah, and I always and then you've got to look at, so do you do those strength program when they're fatigued? So do you do it before training or after training? And I'm probably at the school where saying you should do it when they're fresh, and then recover.
Definitely. I mean, that from a movement perspective, I think that makes complete sense. Because if you do it post, when they're fatigued, you're more likely, if you're pushing higher loads, you're more likely to bring in, lose form, bring in higher injury risk. Interesting. So do sort of pitch conditions affect injuries? I know, we see, and there's well documented evidence that, some of the 4G Astros are problematic for your non-contact injuries, like your ACLs and that sort of thing. Different boot styles and cleats and that sort of thing. But do different grasses make a difference?
So 2 factors: quality of surface and size of the space. So generally, synthetic pitches, just because you don't have the give in the pitch, will certainly increase your risk of calf injuries and other contractile injuries, but predominantly calf. And we're very careful.
What about ACLs as well?
Yeah, I mean, it depends what type of practice you're doing on there. But a lot of pros do not like playing on 3 and 4G pitches. The most important thing is probably the space. So we talk in football about intensive and extensive work. So intensive work will be when you're working in a small space. So lots of accelerations, decelerations, lots of change of direction, really high loading. So if you have an accelerometer on at that time, you'll see really, really high loads. Basketball is a great example of that, really high loading sport. And that's something you've got to be really, really careful of. And I think, again, that's always something that I'm emphasising to patients. Space, size of space. In terms of your load, which is, probably the most important metric that you're measuring in these guys.
So if you've got more space, within an active environment like football, you're more likely to reduce your risk a little bit.
So you open up a different type of injury there. So you're more likely to hit top speed, and then you're into the realms of contractile injury, high speed running injuries, hamstrings, which we know
But a
all
smaller space, are you more likely to introduce pivoting type
and
stresses?
also generally that sort of load related eccentric fatigue that you get in small space.
the braking that you get within.
Exactly that.
Yeah. Okay. So eccentric. Just for people who are listening, eccentric is where your tendons or your muscles are actually trying to break that movement.
Yeah.
Okay. Cool. So I think footballers are still averaging about 50 injuries per team per season, which is pretty incredible. And some teams seemed to go on just a bad run of injuries. Is that, we often see that maybe that happens when new coaches come in? Is that because there's a change of philosophy and the performance team perhaps haven't had time to build up the players?
Any change is a risk, isn't it? It's the same as having changing your shoes. So I would say to patients, look,
is that why you always wear the same old shoes?
Yeah, exactly. So if you're changing shoes, you're introducing a biomechanical change, which may be beneficial, but it might not be. And it's the same with, any team that has a new coach. It takes a while to embed that communication and that rapport with the coach, so that they gain your trust, and then you can manage the players jointly. And it's always, and when a manager changes in the football team, it's always really sort of disorientating. It's a time of high anxiety, and it's a pronounced period of change, which comes with a risk.
Yeah. Okay. And because it's just a change, so it's a risk. What can you do from a performance department point of view? Is there anything that you can try to do? Okay, clearly you've got to set up open lines of communication and develop that rapport with the incoming manager. But is there something that you can do to future-proof these players a little bit more?
I mean, it's difficult because in 99.9% of situations, you won't know who that coach coming in is. You'll know a bit about him. But you won't know him and his team and what they're trying to do. And probably most situations, the club executive team won't know either for, much before you do. So other than the really simple things of making sure the players are resilient, making sure they speak to you, making sure they really focus on recovery, I think that's really important. But it's hard when you say to them, manage yourself, and they're not going to do that because... they're competitive animals. They want to impress a new coach. And so that's the one thing I'd say is don't rely on a player to manage themselves. Try and control the controllables you can.
Yeah, definitely. Okay. So you touched on two little points there that I'd love to sort of expand on. Recovery and resilience. And we talk about sort of mental and physical resilience. So as a performance director in that sort of remit, how do you build that sort of physical and I suppose mental resilience? What can you do? Is that a work hardening? Is that building load into the system over a period of time so that you're pushing strength gains?
I think so no mystery to what I'm about. So a good strength component, really underpins everything you do. And I think, again, sort of rolling that forward into the real world, it's people often talk in terms of strength, in terms of gym work, in terms of black or white. So you'll have a consultant or surgeon say to you, you can't run, you can't squat. Actually, you need to squat in the right range, with the right load, with the right technique, with the right frequency and the right recovery, and it's a great activity.
Yeah.
Similarly with running, and I had this conversation, maybe twice yesterday. So patient of mine who's 6'2", bilateral wear and tear of his hips, trying to run a 3-hour marathon. You're not going to do that on a normal program.
A decent athlete, a 3-hour marathon.
I mean, you're not going to do that on a normal program. It doesn't mean you can't achieve that because, clearly at the times you're running, you're going to be able to get pretty close. But you're not going to be able to do that on a volume-based program. You know, given the anthropometry and the biomechanical restrictions you have.
Yeah. So essentially, what you're saying is that the training program needs to be smart for him.
Yeah.
So okay, you know, use things like blood flow restriction devices for your strength training, or okay, can he do more cardio work on a bike?
Yeah.
Or cross trainer to build
Exactly
his cardio, but you're not loading the hips as
So you can do zone
as
2
much.
on a bike or cross trainer for hours without having that sort of
Impact loading.
impact and that landing mechanics, you know, related fatigue that you can have when you run.
Yep. And look, there seems to be lots of evidence out there.
Yeah.
We're digressing slightly from football, but that running doesn't necessarily lead to wear on
it's straight line activity.
Yeah.
You know, so it's a
on your
change of
cartilage.
direction. And again, you know, so it's constantly with patience in that running in a straight line is much easier than playing squash or doing a martial arts and the load on your body. So I think that's really, really key. Another thing, you know, which, you know, probably again digressing from the football side of things, is it a clinical problem or is it a performance problem?
Yep.
And actually, I see a lot of performance problems get mislabeled as clinical problems because they're seeing the wrong team.
Yeah. Yeah.
I know you'd see that a lot.
Yeah,
I mean,
yeah,
that happens a lot.
Yeah. Yeah, we do. And so in that sort of setting, you know, and we see it a lot where actually, you know, athletes are breaking down purely because they're just not strong enough. They don't have that resilience in the system. They don't have that ability to cope with the sort of load that they're trying to put on themselves. And it's not necessarily a big clinical issue. They've just got to get shit strong.
Yeah, I think commonly no strength base is the first thing to go, and no variety in training. They want to run long and slow, and training errors are huge.
Yeah. Okay, so you mentioned recovery.
Yeah.
So we talk about that a lot with our clients, and how do footballers try to optimize recovery? What are the sorts of things that they do? Is it from the word go when they get off the pitch, you're sort of seeing them handed some gels or handed bars or drinks? What are some of the phases of recovery that they can go through?
So two absolute foundations of recovery: nutrition, sleep.
Yep.
Nutrition, that golden hour after you finish the end of the game where you get accelerated carbohydrates.
Is it just an hour, or is
it might be a bit longer? But I mean, I think, you know, you've really got to work that first hour. So you want to get calories in a right base into them as soon as you can,
and then, protein.
So, you know, that will be, you know, a macronutrient mix dictated by the nutritionists. And then you want to get them eating a proper food as soon as you can. So effectively, refuel with protein as soon as you can.
Yep.
And then a meal, ideally within an hour.
Yep. Okay. And let's maybe loop back to that sort of nutrition. If particularly if, you know, there's a late game and how they manage that. But then you touched on sleep.
Yes.
So sleep is just key for every individual. We know that. We know the detrimental effects of you know, either poor sleep or not enough hours, and that exposes injury rates across the board, but also increases sort of chronic disease risk.
Yep.
So what are these elite level footballers need to do to optimize their sleep? Well, particularly after matches.
I mean, I think the hard thing is if you're in a high performing team, you're in hotels a lot.
Yeah.
So making sure the quality of the mattress and the environment of the room is as good as it can be. But again, you know, I think it's very difficult to overly look at this with science. So that if the other thing I would say to people to remember is these guys are humans. You know, they're people first, they're athletes second. So, and the season goes on relentlessly. So if you're having an extra night in a hotel, rather than getting home at 4 a.m, sleeping in your own bed, seeing your kids in the morning, you know, I think you've got to go on the side of the emotional and social side rather than the scientific bit. But there is a balance.
Yeah. Okay. So essentially, they need a good quality sleep. but you've got to balance that if they're sleeping in hotels.
Yeah.
So having, reasonable pillows,
Yeah.
reasonable mattresses,
Yeah.
right temperature room, making sure they're trying to get enough sleep. But if they don't at that point, they can sort of back end their week a little bit to catch up, can't they?
So the other thing is, remember, you're looking at this whole sort of life of a week.
Yep.
So if you're playing in, you're playing in, Russia or somewhere like that on a Wednesday night. Now, in theory, you might think staying over and getting a good night's sleep is advantageous. But then you go home, and then you come into pressure from your family, your wife, and your kids.
Yeah, because you have to
that
spend time with
outweighs-
them,
exactly.
and
outweighs the advantage of the science. Comes back to saying, why I'm a big fan of data-informed rather than data-led, because I think those type of human interactions are really important if you're going to get the most out of a team.
Yeah. And I mean, I've done lots of different events in the past, and I know you have as well. And often sleeping the night after a big event can be pretty challenging, and particularly, say, the footballers, if they're playing a night match. So are there strategies they can use to help with that? And a lot of the time they might be caffeined up and
you'll give them
adrenaline.
a good dose of casein, and make sure that the room environment is absolutely right, so it's not too warm, and I think that's how you do it.
Yeah. Okay. Cool. So looping back to, actually, no, I wanted to just touch on more on other recovery strategies that footballers are using.
Yeah.
What else might they be doing in the following sort of days? Are they using the cold plungers? Are they using saunas? Are they using hyperbaric chambers at times?
Yes.
Are they having massage and the tissue work?
Yeah.
Okay.
So I think they'll use everything that they find effective. So I'm a big fan of cold water immersion. I think it's very effective. It certainly makes me feel good if I do something. And I think it's a really important tool. What I always say to people is, don't worry so much about the temperature. Cold as you can, as early as you can. So if a cold bath is the best you can do, it's much better doing that early than waiting to get in an ice bath an hour later.
Yep. And that's the cold. Sorry, the cold is super useful if you're trying to accelerate someone's recovery.
Yes.
But if you're trying to optimize the physiological changes in a training cycle, perhaps it's less useful at that point in time.
So certainly in pre-season, you're a little bit more when you're trying to, again, the word eccentric. So you get that eccentric activity, and you're getting a lot of muscle adaptations, and you don't want to blunt them by the cold water immersion. But again, that is very, very negotiable and independent player with each player.
Yeah,
individual with each player.
Yeah. Okay. Cool. And massage can be super key to just optimizing how their performance.
So massage culturally, very, very important, and I think very valuable. But it's really easy to set a tone of passive recovery, whereby a player will come around and do very little and sit on it. It's easy to do that. Whereas, I think passive recovery, but active recovery is absolutely key. So warm down activity. And interestingly, in a warm down activity, if you do it on a bike, I think there's got to be a little bit of intensity to it.
Yep.
So otherwise, it just becomes very slow, very boring.
Is that also because it helps flush the system a little bit more? That intensity just drives to sort of get rid of the inflammatory products that you built
so
up.
You're increasing blood flow, aren't you? And I think it's got to be very measured, very calculated, but it does need to be a little bit of an element of effort in that.
Yeah. Okay. Cool. Let's close on the recovery stuff.
All right.
Hamstring injuries. We've seen a fairly big increase in recent years. Is there
I think if
a
you look
factor
at the
behind that?
current data, the frequency is down, but the burden is up. So that means that when you get one, you're likely to be out longer. So I think that's a relatively robust statistic over the last couple of seasons.
Okay, so the numbers of hamstring injuries that are occurring are less, but the severity
Yes.
of injury is more significant.
And that's largely, I think, because of tendon involvement. Now, two reasons for that, I think. We're now much better at identifying tendon involvement
And we're talking
seeing that as a
more
risk.
proximal hamstring tendons.
Yeah, generally people talk about proximal hamstrings or the mid-belly, what we call the T-junction hamstring injuries. And we're much better at identifying those on scans now than we were even 10 years ago.
Yep.
Secondly, I think players are a lot more resilient and stronger than they used to be. And so when you get one, I think it tends to be of a higher severity.
Yeah. And I think hamstring rehab and the evolution of how we're managing hamstrings has probably come along with in terms of our diagnostic ability as well with scanning. So is it that we're better at identifying, when there might be a fascial involvement or when we need to back off your rehab and allow that?
So I think it's a really interesting area. So if you look at so the BAMIC classification is what people will generally use, and it's a very subjective classification. And I think one of my sort of interests is that that is a very subjective classification.
And can you just explain for people? You're talking about.
So when you've got tendon involvement, it pretty much depends on the volume of tendon involvement. So if you cut tendon in the middle and you measure the cross-sectional area, is it 25%? Is it 50%? Is it more than that?
Yeah.
And obviously, the more of the tendon that's involved, the higher the risk.
Yeah.
I think we're guilty of somebody who's got a 3C report being labelled as all 3C, risk is high, that's at least 6 to 8 weeks, 2C, or it's 2 to 4 weeks, rather than sort of objective-based recovery.
Yeah.
And I think we've got to get a bit better at that, and we've got to, the medical teams have got to probably be a little bit more discriminatory about how they run the rehab.
Because the BAMIC classification is done by the radiologist who hasn't clinically assessed that player.
Yeah, and he's eyeballing it as well. He's not measuring it.
Yeah.
Generally.
Yeah. So this is where, that differentiation between what you're seeing in terms of someone in front of you and assessing and what you're seeing on some images, which sort of goes back to, we don't treat scans.
Yeah, exactly.
We treat humans who are sitting in front of us.
The scans are powerful information, but you're absolutely right. We're treating a body, not a picture.
Yeah. Okay, so cool. So I think we've touched on some of these other types of injuries, but ACL injuries, we seem to have seen, maybe it's the media reporting them, but we seem to have had a bit of a spate of those over the last 18 months as well.
I mean, I think you've always seen them. I think it's just the nature of the game. It's a game which involves touching and sort of twisting and turning, and that's always a risk.
And why the nature of an ACL injury? Why is it that we often see it in skiing injuries or rugby or football in non-contact?
Yeah.
Is there an issue with central fatigue towards the end of season where they're happening a little bit more, or is there just some guys are just unlucky?
Well, I mean, I think it comes down to neuromuscular control. So clearly, if you have a huge twist with a fixed foot, anybody's going to be at risk. But it's your ability in the...
Is that why the Astros surfaces are a little bit harder?
Yeah.
And higher risk because your foot plants a lot more. It doesn't have
but
that
also,
little give.
It's not a natural surface, so you can't rotate. It's not like rotating your studs.
Yeah.
So it's very, it's very sticky.
Yes.
Sticky
so
and
it doesn't have
hard, and
that
you can't-
slide or
exactly
that ability for the foot
Exactly.
to twist a little bit.
So I think all those elements, so what type of athlete is the player? How fatigued are they? What's their neuromotor control in that? And what's the particular scenario you're confronted with? All those elements come into play.
Yeah. Is there a way that we can possibly predict
There is.
with
I mean,
athletes?
one injury,
these?
when I was thinking about this, so one injury I think about a lot in my time in the Premier League was an ACL that happened on, a player that I'd known for a long time and, I was close to. And we've been managing tendon issue for a long, long time. Managed it. He did an incredible job. And then in one game, he ruptured his ACL when he was in his late 20s. Now, I think probably the pain that he got on top of the load of the games and the fact he carried on playing, at that time, his neuromuscular control was probably suboptimal, and that was probably enough to tip him into that incident where he has a ruptured ACL.
So concurrent injuries or having a previous ACL on the other side is a massive risk factor.
Yeah,
definitely. Okay,
and
cool.
you can't sanitize all of that in professional sport. So I think we've got a duty as healthcare professionals to really minimise the risk, but you can't eliminate it.
Yeah. No. I mean, sport is by its very nature. There's a degree of risk there.
Yeah, that's why people love it.
Yeah. So you see a lot of knees.
Yes.
And there's lots of different sort of basic advices around how to manage a knee. And, we generally try to steer people away from surgery. And you've seen, lots of footballers' knees over the years.
Yep.
So, and there's lots of sort of injectables around. Yep. And I suppose my basic premise when I'm treating a knee or rehabbing a knee is that we've got to get that individual as strong and as stable to provide the support to the joint. But where is there a place for your CSI injections and then maybe your PRP injections or your lubricant injections and then arthrosamid is a new kid on the block as well. Do you have, what's your opinion on that?
The principle's the same, whatever injection you're doing. So two ways of looking at it. I always say to patients, look, we're injecting you to open the door to rehab. So the injection is not the treatment. The injection is the start of the treatment so we can rehab you. And I think more than anything else, that is where people go wrong, where they use a steroid injection as a standalone treatment. And that will end in disappointment.
Because only knowing clinically, there's a lot of doctors who don't educate their clients in that way because really it's got to be seen as a window. You've got this window of opportunity.
Well, so the other way I explain it to patients is we've got two jobs. We've got to get you out of pain, and that's what the injection helps. And we've got to keep you out of pain, which is where rehab is absolutely key. And if you don't do that bottom bit, I'll be seeing you again.
There's a lot of bad press about corticosteroid injections. And a lot of people are like, oh, no, I don't, can't I have PRP or stem cell stuff? Why do you think that is?
Because when you're looking at the biology of the situation, then there are lots of downsides. But I'll give you a great example. So I'm a big fan of steroid and, I use it a lot. And I use it because several reasons. One is it's inexpensive. Two is the insurers are approve it. And three, it's got a really reliable effect if you use it appropriately. Now, what you don't want to be doing is abusing that and doing it 3 or 4 times. Generally, I won't do a steroid injection more than twice. But to give you an example, I'm doing one tomorrow in a patient I saw on Monday, athlete with a chance of going to the Commonwealth Games next year, with a nasty knee injury, time pressure, long conversation about the pros and cons of steroid. But, her whole athletic life is on the line next year. So agreed with her, we'll do the steroid injection, we'll give it a time window, and then we'll move from there.
Okay, and so they're pretty effective at knocking pain down, aren't they? And they're a powerful anti-inflammatory agent, aren't they? And so at the right time, they can be quite useful for certain situations.
Another example. So something I see commonly is if people have knee pain
Yep.
and become inactive and put on weight, and then it's become more painful. You've got to break that cycle.
Yep.
So again, it's part of your rehab and your holistic approach. You've got to take advantage of the window we give you with the improvement in your pain.
Yep.
That might be we teach you how to move better, and you can move more.
Yep.
You can load more, and you can reduce your risk factors. And it's amazing how effective that can be.
Yeah. I mean, getting people out of pain just means that, there's such a stimulus to want to move and to load and be, they can be more effective with their exercise. So I completely get that. But patients are always like, and they often need that discussion. But I think a lot of the time that's where the education piece with some people seems to be missing, where they sort of see this as the quick fix rather than, okay, this is part of the solution to change the drivers of what led to you getting in this situation in the first place. So lubricant injections and sort of stem cell PRP, where do you sit with lubricants?
Generally I'll use a BRP preparation along with iAlgan.
Okay,
so I do the two together. Yeah. Yep. So I think there's some reasonable evidence around that. And there's no doubt that patients can respond to that.
Okay.
And we have some reasonable results with it.
And are there other situations where you might use PRP as well? And what's the difference? And maybe we should explain. PRP is platelet-rich plasma.
Yes.
So how is that different from stem cell sort of injections?
So effectively, when you're spinning down plasma,
the patient's own blood.
Spin it down, and then there's a straw-coloured fluid comes off, and you're trying to put positive growth factors back into the area you're injecting, which really is acts as a biological anti-inflammatory. So you're not going to see the cells regenerate. And the idea is with stem cells is that you take a generally sort of generalized cell, put it into an area of injury, and it will regenerate. And will regrow, so you'll get some sort of reconstitution of the tissue. Now, it's a very controversial area. I think our knowledge of that is only starting, and I think you can spend a lot of money on very poor evidence.
Yeah, and look, the stem cell therapy, and there's lots of ways you can halve the stem cells. They're generally pretty expensive.
Yeah.
Compared to sort of PRP, which is still a little bit costly, but it's a 10th, a 20th of what you pay for stem cells. Yeah. And so that combination, you've seen that being successful in knees with PRP and
iAlgan.
iAlgan. Yeah. Okay. And what's iAlgan? iAlgan, that's a hyaluronic acid.
Yeah. So it's effectively almost a substance that we put into the knee, which will improve the quality of joint fluid that the joint produces, and as sort of anti-inflammatory and lubricant positive effects on your knee.
So it's almost, in essence, mimicking your body's natural synovial fluid.
Yeah. Trying to do that.
Yeah. I used to
improve the quality of it, which gets downgraded when you're injured.
Yeah. Okay, cool. That makes sense. And they can last. You can repeat both PRP and the hyaluronic acid, can't you?
Yes.
Are you is there a time frame that you're...
No, I mean, so a lot of people would say you need 3 of these. Now, I don't think there's any evidence for that. I generally do it once, keep people under review, and use that to really spear the rehab. And then if they need another one, then that's something we can offer further down the track.
Yeah, okay. But again, this is part of that offering a window of opportunity where people are like, okay, right, we've done some PRP, we've put some hyaluronic acid in, we're trying to optimize that environment for the joint to function off, but now we've got to hit the rehab really hard. Yeah, and do everything possible to optimize that. Yeah. Arthrosamid is a bit of a new player coming to the market, which seems to have pretty good results.
Yeah, so I've been doing that for nearly 2 years now, and in the right people, it can results can be excellent. So Orthrosamid is effectively a gel
Yep.
which forms a protective barrier in the lining of the knee,
Okay.
and can give you up to 3 years relief. So
Yep.
for people with higher grade arthritis who perhaps have had previous injections and really it's not the right time for them to have surgery for whatever reason, it's a pretty good option.
And so the evidence, if I'm not wrong, was perhaps suggesting that, okay, those people who are a younger cohort
Yes.
who've had
Yeah.
a fair bit of degenerative
Yeah.
knees, so maybe, your footballers,
Yeah.
your rugby players
Yeah.
who've done a lot of pivoting sports, or
Yeah.
your tennis players, hockey players, could be good candidates
Yeah.
for this. And they're the really strong responders.
Yeah.
Is that right?
Yeah, and we're running a group of ex-footballers for Arthrosamid at the moment with the League
Okay.
Managers Association. So we're part of the way into that, and I think you're right. Yeah. Younger people generally are more likely to respond than people who are a little bit older.
Yeah. Okay. Is that the case across all sort of injectables?
Probably. I mean, to a degree.
Yeah.
So fitness, muscle mass, all those things, I think, generally contribute to your success rate.
Yeah. And again, with the Arthrosamid,
Yeah.
and that's a one visit,
Yes.
but it's 6 1 mil injections. Yeah. And actually, the knee can be a bit grumpy after that, can't it?
Yeah, I mean, in some people. In some people it
because you're
can
putting
be.
that's a fair bit of volume.
Yeah, I mean, it's quite a viscous injection.
Yeah.
And it can be sore for, a number of weeks. It isn't usually.
Yeah.
But it can be.
Okay. And the material takes about 6-ish weeks to start binding.
Yeah, I mean, we don't generally tend to think about judging outcome till 3 months.
Okay.
So 3 months, you hopefully start to see an improvement. 6 months, you start reach your maximum improvement, and it's a little bit towards 9.
Yep.
And then generally that's maintained for 3 years.
Okay, cool. Okay. And so how would someone choose between that PRP and hyaluronic acid injection versus an Arthrosamid?
Well, age, what degree have you had injections before?
Yep.
What degree of joint change have you got? And, what are your aims and outcomes?
Yep. Okay.
So, I mean, I think all those things come into play. Now, Arthrosamid is not an inexpensive injection.
Yeah.
But then PRP and, Ialgan, if you have that done 3 times, which some people do, you're probably talking about very comparable costs.
Yeah. Okay. And do you have a gut feeling which might be better for I think the stage 3, stage 4 OA changes in the knee, which is quite moderate osteoarthritis, are they meant to be a little less effective for any of these injections?
No, I mean, look, it depends again on your rapport with the patient, what they're looking for. But I think in my hands, in my practice, I know where I am with Arthrosamid. It's a pretty reliable outcome.
Yeah.
And,
Okay.
It's a bit like steroid in that way, in that you can kind of, looking at the patient, looking at the situation, you can predict, how they're going to respond quite accurately.
Yeah. Okay.
And I think that's a big advantage. Whereas with Ialgan and BRB, I always say to people, it's some people respond, some people don't. But because of the nature of the preparation, it's very, very unlikely to make you worse.
Yeah. Okay. And do you always do the PRP and Hyaluronic together? Are there times when you don't?
In the knee, yeah, of course. I think it generally, I mean, if I can do a PRP and when I do a Hyaluronic, I will do. Because I just, again, in my hands, I think when you're going to that rehab phase, I think there is that added value.
Of adding them both together. Yeah.
Definitely.
Okay, cool. And if we're looping back to, say, professional and elite sport, where do these injections fit within, getting athletes back in the field of play? So I know that perhaps that's sometimes controversial with steroids. Do you inject a knee a couple of days before a match to try and get them back on the pitch?
Yeah, you can do that. Look, I mean, I think there's, again, some rules and sort of practice, guidelines which are really helpful. One is any doctor is bound by its professional code. So, you've got to speak to the patient, you've got to be truthful with them, and, you've got to record your examination and your interventions very accurately. Secondly, in that context, what the patient wants is key, and the patient is likely to, in that scenario in a football team, the player is going to want to win. He's going to want to play.
And they want to get back on the pitch.
So as long as you've been truthful and you communicated, the situation very carefully and very accurately and recorded it, then, as long as it's safe, then you support the player to do what they need to do.
Yep. And is there an ideal window for something like that? I'm sure it depends on the pathology and depends on
I think
what's going on.
Ideally, if you're going to do a steroid injection, you want to do it at least 2 or 3 days from the game.
Yep.
You don't want to be doing that the day before or the morning of. I mean, that would be challenging.
Yes. Yep. Because often they can get feel a little bit worse before,
particularly with a
better.
joint. So if you're putting steroid into a joint, you might well react to that.
Yeah. Okay. Cool. That makes sense. So, where do you see the future of injectables going? And are stem cells going to have a bigger role? I mean, people come in and ask for it all the time. These what we call biologics. Are there any other different things coming to the market?
So I think there's immunological patterning. So I think there's a lot of work being done on that.
Okay. And what do you mean by that?
So they'll look at your T cell patterns and your immunocyte.
And T cells are sort of immune cells. Yeah.
And they'll look at your times of high risk of injury and recovery, and I think so. There's a lot of work going into that, and that in terms of health prevention or injury prevention, that there might be maybe some mileage in that.
Yep.
And then I think in terms of where we go in the future, I think we will get there with biologicals. We probably will get there with stem cells.
Yep.
I mean, to my mind, we're a long way off being able to do that safely and reliably.
I mean, the science is incredibly good behind it.
Yeah.
But the hard evidence to suggest when and how and why we use it doesn't seem to be quite there.
I think it's a bit disappointing sometimes the way these really speculative treatments are sold by doctors. I think sometimes you'd expect to do a little bit better than that, but I think we're a long way off being able to offer that really reliably.
Yeah. Okay. What about sort of testing genetics and sort of DNA profiling of people? I know pharmacogenetics is a big area. And identifying, what drugs someone might better respond to. Do you think, and I know in just touching into another area, they're starting to, when they're screening potential players, they're starting to look at that and identifying, does someone have that certain athletic gene, although there's not one athletic gene, but multiple. Is that a big area?
Yeah, I think so. So in terms of that sort of genotyping, where you can have a look at patients' injury risk and, again, form that sort of passport, idea of where their risks come. And then the other, I think, would really be helpful would be a predictor of which intervention is going to be effective in terms of injections. And I'm led to believe that, there will be some breakthroughs on that in the next few years.
Okay.
So, ideally, which joint is going to respond to a PRP injection, which is
a steroid injection better with.
Absolutely.
Yeah. I mean, that seems like the way forward in terms of understanding, because whilst medicine's a science, it's still a bit of an inexact science a lot of the time.
Yeah.
And everyone seems to respond differently.
Yeah. It's again another another line is I always say to people, look, when we're talking about movement, when we're talking about joints, when we're talking about muscles, we're not talking about cutting out an appendix, and that's the end of it. You know, it's not anatomically based; it's movement based, and I think that's an area of medicine which we do incredibly badly.
Yeah. Okay. Cool. So lots of scope to improve and
Absolutely.
and
And we're all
understand our
committed
knowledge.
to doing that, right?
Yeah, definitely. Mark, I've loved our chat. It was super interesting. I've learned a lot. Hopefully, our listeners will have. I'm sure there's so many other things that we could probably dive into, and maybe we'll do that at another time. But thank you for your time.
Pleasure to see you.
Okay, thank you. Cool. How's
All
that?
right. Yeah, good. Good.
Enjoy that?
Yeah, it's okay. It's been a bit bright light towards the end.
Yeah, you're probably looking into it more. Cool. Thank you, mate.
Lunchtime.
Yeah. That was good.
Yeah, no, good.
It flowed pretty well, I think.
Yeah. Who have you got up next?
I've got the chief scientist of First Beat talking about sort of recovery profiles, HRV, performance stuff. I did one on Tuesday with Dr. Wendy Denning, an integrative doctor on GLP-1 agonists.
Did you?
It's one I felt like I didn't know, wasn't able to speak as confidently on, but it was good. It was slightly shorter. But I want to get a sleep guru on. I think that'd be quite cool. And probably actually maybe someone to just talk recovery.
Yeah.
Overall recovery parameters. So I've got to search for that. But that'll mean, I think after I've done that, this is the 5th one I've done, and then I'll...
What do you get somebody on from Lanzarote talking about functional gut microbiomes and that sort of stuff?
Yeah, that'd be a good shout.
Yeah.
Yep. Who's big in there?
There's a lady there. I need to meet her.
Yeah.
Because I think that is interesting.
Yeah, definitely. That would be a good one. So we're getting there. We'll probably start launching them over summer now.
So that's what's the name of the firm? I've got a second interview with them in 2 weeks. What's the name of it? On the Scope.
Okay.
Have a look. I think the ones I've showed you, but they've
What are they doing?
So that's the T-cell people.
Okay.
And they've done a lot of good work.
What do you mean you've got an interview?
So they're looking for a sports medicine CMO.
Okay, cool. On the Scope. Oh, yeah. Boost performance, optimize health span.
So look what they've done with Barcelona. And it's interesting, but like all things, said to them, I mean, they all make this mistake. It's same with Nitro. Look, unless you sell to the masses, there is not enough elite.
Yeah.
Because they think, oh yeah, it's tested, it's about $5,000 or something. And they're not going to spend that.
Yeah, okay, I'll check
So
it out.
unless you can find a way to scale it, sell it to the faux pros who do have money and will spend some money.
Yeah.
Anyway, data obsessed, then you're not going to make money.
Interesting. Where are they based out of? The US?
Yeah.
Who's on their
Nobody I recognise.
board? No?
Nobody I recognise. They're all sort of, and their funding is a little bit.
How much have they raised?
Well, that's so the next round of interviews is with the founder.
There's
I
a
don't think they've got a lot of advisors, so they want a full time sports medicine CMO.
Do you want me to dig? Because there's a very good website.
Oh, really?
Yeah.
Look at you.
There's a very good
Business
website.
intelligence.
Let me just message Anna because she does all this scoping for us. What's the website? Because this incubator's been really fucking interesting. Like they're very, very specific and driven in terms of, okay, what's your route to market? Like it's super aggressive. The amount of homework they've set. Next week, there's a 90-minute stress test that they put you through to see if your product, because essentially they want to back a unicorn.
Right.
And they want to understand, our problem is that I think our product's great in that we're pulling data from wearables. We've got a behavioral health AI coach to coach people. We're putting in a movement screen as well. So and then we're creating a social aspect to it as well,
Right.
with peer-to-peer. Our use case was sort of burnout, okay, in clinicians. But I just don't think it's strong enough, because essentially what we're really doing is optimizing health.
Yeah.
But I don't know that we've got that product market fit right for this product at the moment, because you sort of need to be seen to have a solution to solve a problem. And I think ours is almost like a nice to have, optimizing health.
Yeah.
And if it's a B2C, so getting out to the consumers, that's another thing altogether. Our idea was that it would be a B2B2C. So either getting it into HCA, Fortius, Cleveland as a tool for doctors, but then once we got proof of concept, filtering it down to the clients. But it's interesting just going through this process, and it really, just learning a shitload in terms of how to think about scaling a business and making sure that you've got the right product and the right fit and the right market.
Yeah.
I've just asked Anna.
It's amazing a number of times people. I mean, I think I probably told you. So Cleveland invested millions in its performance centre in Cleveland with Cavaliers. I said to the CFO, "Where's your income stream?" They have no idea. They just get carried away by, this is great. This is great science, and they don't know what people are doing already.
And that's what I think Okay, cool. That's what I think I've been pretty good at in building our clinics out, because I've understood all of that, but I haven't mapped it out in that way. No. It's almost that I know what I can do, what I can drive, and what I can deliver, and I've known that I've been able to leverage my network and clients to make all that happen. But actually then getting in front of investors or getting in front of advisors and having to talk the game just means you have to know it to a greater level. I'll show you this. Hang on. Oh, it's on my laptop, I think. I'll pull it out. This thing that I built for Saudi.
You want to grab some food? Yeah. I know where to go. You hungry?
I'm always hungry.
Sandwich?
No, I'm not having a bloody sandwich.
Oh, mate, there's
pulls and then it's delivered a whole deck as well, like all the slides. And I did some market analysis on ACA actually last night. But it's sort of what our key differentiators, who our ideal clients are. It then identifies who our ideal persona is.
Yeah, I like that. I
Yeah.
like that. That's great.
And then it looks at,
It's
okay,
really good. Yeah.
yeah,
That's great.
the ideal persona.
Yeah,
That's
good.
exactly
Yeah.
what they are.
Yeah. Absolutely.
And then it's got, I've asked it to think about sort of routes to market. And this is what we do that's low cost. Like, the PR stuff, getting into clinics, you just got to work it from the ground up, I think. And then, okay, a little bit of top sprinkling of, okay, get your Ronaldos in. And they do have a link in with Al Nasser.
Ronnie.
They're,
Come on, let's go get some food.
but yeah, there's such good AI tools out there.
Yeah,
So
this is interesting. So even Youngstein's using it.
sorry?
Even Youngstein's using it.
Who's using it?
Sharon. She had a meeting for being badly behaved at Cleveland this morning, and I got this note once she came out. She's clearly
Well, she's been badly behaved.
look. So suddenly on the way out, I said, look, here's the note. So she's clearly putting on some dictation software.
Yeah. Oh, you need to.
Yeah.